Greetings, everyone. My name is Rebecca Miller, and I am an MPH and MS Nutrition dual master's student, and I'm delighted to present my work on health communication for health professional students with a focus on improving health outcomes through the acknowledgement of the presence of social disparities as an indicator of poor health, specifically for Black and Brown patient populations. As countries continue to diversify, culturally responsive providers are invaluable to disparate environments. Based on a landmark Institute of Medicine report titled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, it is evident that minorities face inequities inside and outside of the health system that negatively affect their outcomes. In an effort to bring disparities to the forefront of medical education, the proposed training was created with the goal of coupling lived experience with evidence-based methods of curricular design to better instruct future healthcare providers on the operationalization of health literacy and communication. Consequently, reflections from my experiences as a patient and family patient advocate, visual narratives, a literature review, and feedback sessions with primary stakeholders served as the basis for this mixed methods approach. A full exposition of my methodology will be presented at Innovations. For this poster session, I will briefly discuss my results. To begin, the visual narratives portion of my work highlighted the importance of Black family structure and social outcomes, tradition and culture in health outcomes, role models and exposure to opportunities and positive self-image, and fundamentals of building sustainable neighborhood relationships. A photo of my sister and I on the steps of our childhood home in Mount Pleasant neighborhood from the importance of Black family structure and social outcomes visual narrative has been included as this upbringing was essential to the creation of the narratives. Following reflection, negative feelings of insignificance, disregard, misunderstanding, and disrespect stem from clinical encounters where rapport and relationship building was neglected in clinical encounters. Complex medical terms were not fully defined, and the patient advocate was asked who they were after inquiring about the interpretation of clinical results. Positive feelings resulting from reflection included trust and commitment, which were formed through long-term relationships with one primary care physician until adulthood, and intentional follow-up after life-threatening lab results. These findings culminated in the creation of Module 2, Community and Neighborhood Context, Social Disparities at Their Source, and Module 3, Cultural Competency and Representation, the Legitimacy of Lived Experience. A literature review was conducted to further validate these findings in the lived experience portion of my research. A total of 77 papers were selected for peer review prior to reading the full sources. Ultimately, 47 articles were selected for systematic review and inclusion in the full literature review process. My literature review further confirmed my lived experience and illuminated time periods where medical racism has stained the trust of Black and Brown people. In order to bring awareness to this need, I created the History and Policy, Major Transitions of Black Americans module to discuss the relevant history and how it relates to health. Additionally, the Social Determinants of Health, Distributions of Resources, and Disease Self-Management module was designed to address how poor availability of resources can lead to poor disease self-management. Lastly, the final module, Application of Social Determinants Framework in Medical Practice, was designed to leave trainees with concrete examples of how the principles introduced throughout this training can be applied both in clinical settings and within community. Feedback sessions were conducted to gather feedback on the aforementioned modules from practicing clinicians, community health workers, and health professional students. The two one-hour sessions garnered 27 participants in total. In Figure 1, you will find my participant title composition, which shows an overrepresentation of community health workers. This overrepresentation is a major strength of the feedback sessions, as community health workers are a bridge between the community and healthcare access. The results showed the participant recruitment suggestions centered on working with academic program directors and making the training accessible and mandatory. Participant suggestions for training improvements called attention to the importance of live and case-based learning, multimodal communication, and patient trust. Lastly, participant suggestions for training acquisition converged around cultural competence and listening with empathy. Overall, I found the feedback sessions to agree with the training objectives developed in the lived experience and literature review portions of the module and objective creation process. Based on the means, patient trust and relationship building, and inclusion, diversity, and representation were the top two most important topics to cover, while adapting to patients' learning styles and avoiding medical jargon were the top two most important skills. Although virtual formats were encouraged by students, health professionals in attendance felt that in-person experiences would be most impactful. Additionally, attendees expressed the desire for the training to be a requirement for students. In summary, the chosen modules of this training are structured to enhance the future provider's perspective through a critical examination of patient-provider communication that acknowledges the built environment and culturally relevant implications of physician care plan instruction and patient adherence. Thank you so much for listening to my presentation.